Our last speaker, Dr. Faisal Alkandari. I think Dr. Faisal is well known by many of us. Dr. Faisal is a consultant pediatric nephrologist. He is the head of pediatric nephrology. He was the head of pediatric nephrology department, Mubarak Hospital. Now he is at Al-Ahmadi Hospital. Dr. Faisal Alkandari, American Board of Pediatrics from Canada and from States, and Canadian Board of Pediatric Nephrology. Our topic today will be atypical HUS. So please, Dr. Faisal.
Good afternoon, everybody. First of all, I would like to thank the committee for inviting me for this topic today. And I would like to special thanks to Dr. Fahad, who's sitting in the front. Today I will talk about the atypical hemolytic uremic syndrome disease overview. As you all know, that the hemolytic uremic syndrome is a systemic thrombotic microangiopathy characterized by microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. Most of you are really aware about the typical one, which we call it stick HUS, which is usually caused by an infection that activates the complement. The cause of stick HUS is Shiga toxin produced by certain strains of E. coli. Shiga toxins directly activate the complement system as well as interferes with the normal regulation of complement. So as this activation of the complement happens, then this will start to damage the endothelial cells, leading to platelet activation. And then the platelet activation and the endothelial damage leads to multiple thrombi, inflammation, and occlusion of small blood vessels throughout the body. When we talk about the atypical HUS, maybe most of you are not really aware of this condition, which I'm going to concentrate on today. The atypical HUS is a lifelong chronic disease. It is caused by genetic defects in complement regulation that lead to uncontrolled and excessive complement activation. We have just to go back to the basics. The complement system in the body is always activated by water. C3 and water will just activate the complement system to be ready all the time. And then we have the classical, the lectin, and alternative pathways, which just helps in activating the complement cascade whenever it is needed. So whenever you have a microbe antibody in the body, then this will start those pathways, and then you will start the cascade of complement activation. But like any other thing in the body, there is something to activate and there is something to regulate and also keep under control. We have multiple naturally occurring proteins which control the complement. They regulate activation of the complement. They prevent excessive activation and damage to own cells and organs. Some of them are integral to the normal functioning of complement, such as C3 and factor B, and some of them inhibit and control the activation of complement, such as factor H, I, MCP, and others. So in atypical HUS, what happens that you have a chronic uncontrolled complement activation, which leads to devastating consequences. Through those pathways, you have the C3 activation, then this will go on and on to reach the C5a and C5b9. And these two complements, the C5a, it's a potent anaphylactotoin, it's a causes chemotaxis, it's a pro-inflammatory, and just starts to cause anaphylaxis, inflammation, and thrombosis. The C5b9, it's called also the membrane attacking complex. It causes the cell lysis, platelet activation, leukocyte activation, and simply this will lead to the cell destruction, inflammation, and thrombosis. So this is what happens inside the small vessels, that with the activation, the endothelial system will be damaged, then the platelets will be activated, you will have occlusion of those systems. And usually the first system to be affected are the kidneys, just because of the vascular component. How can we look at what are the clinical measures of the thrombomicroangiopathy? Number one, we have the decreased platelet count because of the thrombosis formation. And this will be shown as if either you will have decrease in the platelet count, like less than 150 that we usually use, or sometimes decrease from the baseline platelets. Because if you investigate the child just in the beginning of the disease, you might see a normal platelet, but in reality this might be a drop from the baseline level. Then the microangiopathic hemolysis, the characteristic thing about it that the Coombs test is negative. Coagulation profile, usually initially it is normal. There will be decrease in the hemoglobin. LDH will be high. There will be low or undetectable haptoglobin concentration because of the consumption. And the most characteristic thing in the blood smear will be the schistocytes, which are broken or fragmented red blood cells. There are similarities and differences between atypical HUS and stick HUS. So regarding the etiology, both of the, as we say that the atypical HUS is just a genetic inability to regulate the complement, but the stick HUS due to Shiga toxin producing bacteria. Both of them, they have the almost similar presentation. Maybe the atypical HUS is more and more insidious and more gradual rather than the stick HUS, maybe, but not always. Regarding the age, we usually think of hemolytic uremic syndrome to be a disease of childhood. But in reality, that about half of the patients are adults in the atypical HUS. And in the recent outbreak of stick HUS in Germany, almost more than 80% of them were adults. What about the diarrhea? The typical way of stick HUS that is preceded by diarrhea. But also remember that even in atypical HUS, you might still have diarrhea in 30% of these children, and as we will discuss it in the cases that I'm going to present. The course, we said this is lifelong. In the atypical HUS, the stick HUS is just usually short time, but might have consequences also. Remember that the Shiga toxin may be negative in the atypical HUS, but sometimes it could be positive. And the reason for this, that there is always the genetic predisposition, and then there is something which just triggers the hemolytic uremic syndrome, and sometimes it could be just the Shiga toxin which might trigger this infection or this gasgate. What are the consequences of atypical HUS? The consequences are devastating. So it causes vital organ damage and sudden death, chronic progressive course with premature mortality. 30 to 40% of patients die or progress to end-stage renal disease with the first clinical manifestation, and 65 of them, they die just in the first year of life, the first year after diagnosis. Does it affect only the kidneys? No, it's a systemic disease. So the atypical HUS, it's a systemic disease which might affect all organs, including kidneys, central nervous system, causing seizures, encephalopathy, blood, as we mentioned, cardiovascular system, it might cause myocardial infarction, gastrointestinal with bleeding and colitis, and also pulmonary with pulmonary hemorrhage. There are some common misconceptions about atypical HUS. The first of them, that it's only a pediatric disease, but actually it might affect any age. The atypical HUS is not an acute disease. The atypical HUS is a chronic, genetic, and lifelong disease. Atypical HUS is not only a renal disease, it's a systemic disease and affects multiple organ systems. The atypical HUS diagnosis does not require genetic mutation. You might find or you might not find genetic mutation, but still the diagnosis could be atypical HUS. What about the plasma exchange or plasma infusion, and what's their role in atypical HUS? These were not have been proven in well-controlled trial to be safe or effective, although most people used to use those measures. How we manage atypical HUS, just a few years ago, we had nothing actually to offer the patients. We used just to go with the dialysis, plasma pheresis, but actually the outcome was very poor. And most of these kids, especially in pediatric age group, they would just have major mortality and morbidity. But thanks for the new medication, which is called eculizumab. This is a humanized monoclonal antibody targeted at a complement component C5. This was FDA approved for treatment of atypical HUS in 2011. Just going back to this cascade, the good thing about the eculizumab that does not affect the proximal part of the complement activation. Therefore, there will be the immune complex clearance will be there, and microbial opsonization will stay, but it will only and mainly affect the terminal part, just stopping the atypical HUS. I will talk now about a few cases that we experienced in Kuwait, and just to show you how difficult is the diagnosis and management of these patients. So the first case, it's an 11-year-old Canadian boy who was living in Kuwait. He was diagnosed with ulcerative colitis. He was followed in Amiri Hospital, treated with Imuran and other immune suppressive medication and steroids. Because of his diagnosis, he was admitted several times to Amiri Hospital with bleeding per rectum. But the last time, which was in December 2010, he presented also with coke-colored urine, edema, decreased urine output, which was also preceded by bloody diarrhea. The investigation revealed just impaired renal function, low platelets and hemoglobin, and fragmented RBC. So it was clear that we are dealing with HUS. This was at 2010 because the FDA approval of eculizumab, and we didn't have the eculizumab. He was started on antibiotics, so stool cultures were negative before doing the investigation. Later, he became more anuric, hypertensive, generalized edema, so we started him on hemodialysis, and we also stopped the Imuran. We thought maybe this is the cause of the hemolytic uremic syndrome. We also started him on plasmapheresis, and with the plasmapheresis, as it happened, like there was some pulmonary edema, hypocalcemia, hypotension during these episodes. After 1 month, when the parameters has improved, we stopped the plasmapheresis, and the parents were actually reluctant to continue the plasmapheresis in spite of our fear that this might recur again.
You have 2 minutes, please, Dr.
We stopped the hemodialysis, and we also stopped the plasmapheresis. But unfortunately, the disease recurred, and the patient had hemolysis, and he ended up with end-stage renal disease. The second case, again, presented typically with the same kind of picture, but unfortunately, again, we didn't have the eculizumab, and we thought that this is just a typical HUS, and unfortunately, this child ended up with pulmonary hemorrhage, and the patient died. The third patient, which we're more lucky, so he presented with the HUS. Initially, we started him on dialysis and plasmapheresis. He started to deteriorate. He almost went into pulmonary hemorrhage. But then we got the eculizumab. This was given day 5 and day 11. So as you can see, the miraculous has happened. So at day 5, the patient started to have improve in his hemoglobin as well as the platelet level. When we gave him the second dose on day 11, they continue to improve. His LDH dramatically decreased, which is an indicator that his hemolysis has improved. his creatinine improved significantly in the first month, but then it continues to decline a few months later. This patient improved completely apart from just mild hypertension and proteinuria. The last one, we just decided to go ahead and start him on eculizumab right away from the second day, and then this is the effect. So from the second day, everything, the LDH came decreased, platelets has improved, his creatinine just within a few days back to normal. So, conclusion that the atypical HUS is devastating disease. Delay in diagnosis and treatment could be due to misconceptions. In Kuwait, and with our knowledge about these cases, and with our experience, we think that, and we believe that whenever we deal with a patient with HUS, we have to deal with him as an atypical HUS until proven otherwise. The earlier that you start eculizumab, the better is the outcome. The major drawback of the medication is that this is extremely expensive medication, and the duration of treatment remains an issue to be solved. And thank you very much.
Thank you very much, Dr. Faisal. We can take a couple of questions.
You've mentioned that it's a genetic cause, and indeed there are about 7 genes described to cause atypical HUS. One of them is the CFH, which is an autosomal dominant, which means that it could be due to a de novo mutation. So have you ever tested any of your patients, or have you? Actually,
we have sent genetic tests, and I just got one of the results just now, and it was normal. But having a normal genetic test does not rule atypical HUS.
Yeah. But did you test all the 7 genes that has been reported, or one
there
of them?
There are more than 7 genes. Yes, we have sent them to through the genetic center. We have sent them abroad to be studied for all of those genes. But there is this is the step 1. You can go ahead and do the step 2 for the genetic testing.
So they did the sequence analysis, you're waiting for deletion duplication testing.
Something like this.
Okay.
Dr. Mazen, maybe you want to ask?
You're welcome.
My question, now it is very difficult to diagnose atypical HUS so quickly. So we have challenge now when we have, for example, weekend coming or holidays, and we have child with all parameters that he have HUS. About starting a treatment, I mean, it is difficult to diagnose nowadays, to have sure diagnosis of atypical HUS. And sometimes it's very difficult to obtain any treatment for these children.
So I understand your point. So yes, the diagnosis is difficult to know from the beginning that this is atypical or typical HUS. But from our experience, if we review the cases over the past 10 years in Kuwait, we hardly had the typical or the stick HUS. So most of the cases that we had were atypical HUS, okay? And just from the progression of the disease, when you not from the beginning, just retrospectively thinking about these cases, these are mainly atypical HUS. What to do when you receive a patient? Would you just start the medication right away? I still would recommend to do the basic investigation for sure. You will send for the Adam TS13. You will do the stool looking for Shiga toxin. You might observe the child for a short while. Of course, taking the history, family history will be very important in these cases. If the patient is deteriorating, by that time, as you're doing these investigations, try to get the medication ready. Okay, because if you wait for a long time, you will get into complication. There is no harm to start the medication and then do further investigation, or otherwise you will be really losing the patient if you wait too long. So for our patients, some of them, we started them on eculizumab, and then for logistic reasons, we couldn't get the medication anymore. And they remained in remission, and we are also following them. But remember that these patients has lived for years without having anything. So anything which triggers them, they might have the disease again.
Okay, there are some recent report about the use of eculizumab in STEC HUS, because at the end complement is also involved in STEC HUS. I don't know in such a case how can be, what's your experience in this, and what's the future of using anti-complement like eculizumab in all type of HUS, although there's a big difference in the pathophysiology of stick HUS versus atypical HUS?
Okay, regarding the studies about using eculizumab and stick HUS, still is, as of my knowledge, still it is ongoing, and still there is no
case report, I mean.
Yeah, there is still no recommendation to start, but maybe in the future this will be the recommendation. I don't know about it.
Okay.
Okay, the answer for your question, the first one, the use of steroids, there is not at all. Neither the steroids or nor other immune suppressive medication apart from the eculizumab. Number two, if you want to wait for the genetic study to come back, it will take months. Okay, even if you are living in Europe or North America, it will take months to get the results because there are special centers to do these tests. And this is not the only thing, that even if you have a negative genetic test, you cannot rule out atypical HUS. So we prefer to start early, not to lose the patient and not to end up with end-stage renal disease rather than delaying the treatment.
Okay, Dr. Ihab, please, maybe last question. Dr. Ihab, you want to ask? Yes, please.
Okay, the duration is not clear yet. For those, I mean, the main recommendation is just to continue forever, especially in those documented genetic study or those who have a strong family history of atypical HUS. For those who are like borderline or you don't have the genetic study, the recommendation is just to continue for a year and then stop and see what will happen. But remember that when you stop, they might have a rebound kind of activity and might get worse than the first time.
Okay, last question.
Thank you very much, Faisal. It's really nice to catch up with you. Just a comment, not a question. I completely agree with Faisal. The study you're asking about, Dr. Bassam, is running based in Newcastle in the UK, where they are running even with STIC HUS. They're giving it early versus placebo or saline, because in Europe we have the opposite of Kuwait, where I worked before. So we have more atypical more STIC HUS rather than atypical HUS, and the genetic testing is only 20-25% maximum what you can get. Being negative genetically will never rule out atypical HUS, and we're seeing the extreme end of atypical HUS in the UK, where they have severe neurological subset up to coning. And the 3 cases I've dealt with eculizumab, the children has completely changed from a child who is posturing their back to completely normal child after few doses. So just a comment of assuring what you're saying.
Okay. Thank you very much.
Thank you very much. Okay. With this, we come to the end of this session. Thank you very much for all speakers.